this morning. He is going to lecture on management of acute myeloblastic leukemia in 2022. This webinar is brought to you by Mumbai Hematology Group. It is supported by Zydus and managed by Perfect Square. I thank Mr. Ashish, Mr. Sumit, and the team from Zydus who have continuously supported our academic activities. Mr. Yash, Kalpesh, and their team from Perfect Square for flawless management of all these webinars. The Executive Committee of Mumbai Hematology Group for giving me free hand in organizing these webinars and their contents. And of course, the most important, our guest speaker for the day, Dr. Lars Bulliger from Berlin, Germany. All our discussants who have been themselves eminent hematologists or medical oncologists, new participants for sparing your Sunday morning, afternoon, or evening, depending upon from which part of the world you belong to. I'll be introducing our guest speaker very briefly. Guest to open this webinar very briefly. Do remember to visit the website of Mumbai Hematology Group. It is www.mhgindia.com. MHG for Mumbai Hematology Group, easy to remember. There is no password. All our academic activities are displayed there, and you can visit them anytime. And you will also get the details of how to log in, which is totally free. Next weekend activities are in hematology. Benign pyruvate kinase deficiency will be discussed by Dr. Rachel Grace from Boston on Saturday, 22nd October at Indian Standard Time, 7 p.m. and the Eastern Time, 9:30 a.m. Next day morning, that is Sunday morning at 11:30 a.m. IST or the French time, 8 a.m. we have the speaker from France, Dr. Roselyne D. Orin. She's going to speak on female bleeders, essentially von Willebrand disease and other rare disorders. Our discussants today are a galaxy of important hematologists and medical oncologists from India, and they are alphabetically put up over here. I'll just briefly introduce them to you. We have Dr. Anupama Jaggi from London. At the moment, she is in Delhi. Dr. Akanksha Garg from Jodhpur. Dr. Deepak Charles from Kochi. Dr. Deepanjan Halder from Mumbai. Dr. Gunjan Prasad from Kolkata. Dr. Gopinathan from Lucknow. Dr. Kunal Goyal from Kolkata. Dr. Mahadeva Swami from Goa. Dr. Nidhi Dixit from Kolkata. Dr. Parthiv Mehta from Bhavnagar. Dr. Prashant Bhatt from Mangaluru. Dr. Priyanka Samar from Bhubaneswar. Dr. Radhika KK from Hyderabad. Dr. Roshini Pandey from Jabalpur. Dr. Sadashivdu Gundeti from Hyderabad. Dr. Satish Kumar A from Bangalore, Dr. S.P. Verma from Lucknow, Dr. S.S. Ray from Kolkata, Dr. Smita Kayal from Puducherry, Dr. Stelin Bala Chaudhary from Hyderabad, Dr. Suraj Goyanka from Pune, Dr. Thomas Kucheria from Bhubaneswar, and Dr. Upendra Sharma from Jaipur. And now it's my pleasure and privilege to invite our chief guest of the day to inaugurate our webinar. And that's my friend and colleague, Dr. Sriram Kane, a very known, huge personality from India, very, very senior medical oncologist, hemato-oncologist, and he runs Dr. Kane's hospital in Nagpur. It's my privilege to invite him to inaugurate our today's webinar and give some words of wisdom. Over to Dr. Kane.
Good morning, everybody. It's really my great pleasure and honor to be here with you all this morning for this session of acute myeloid leukemia. And I thank Mumbai Hematology Group and especially Dr. M.B. Agrawal for giving me this honor. I take this opportunity to talk to my young colleagues who want to pursue their career in the field of hematology. The hematology field has seen a very sea change in last few decades. Somehow in India, this super specialty training and degrees have started a bit late, but now, as far as the choice of super specialty training is concerned, this branch has become a forefront branch as a choice for the young students in hematology. This branch has seen many firsts in the field of medicine. The first chromosomal and molecular abnormality associated with disease. The first use of monoclonal antibody in therapeutics. The first use of targeted therapy in malignancy, and recently a cellular type of immunotherapy in the form of CAR T cells. So these modalities now have become very common and being used extensively in all other fields of oncology and other fields of medicine. But this has started in the field of medicine. Let me share my experience of this field with you. It's an extremely satisfying branch, and you can really help your patients immensely, and especially with all these new therapeutic options now available to you. It has got a great academic quotient, and you can be in touch with academia even if you are doing a private practice. It gives good academic satisfaction and extremely good job satisfaction. I wish to give all my best wishes to the young students in their career, those who are pursuing in the field of hematology. Now we are actually looking forward for a very informative talk on acute myeloid leukemia and a very lively discussion thereafter. I again thank Mumbai Hematology Group for inviting me here. Thank you.
Thank you, Dr. Kane, for those wonderful words and inspiring speech you spared you this morning to address our students and trainees.
My pleasure.
And now it's my pleasure to introduce formally our guest speaker of the day, Professor Lars Bulliger from Berlin, Germany. He's Professor of Hematology and Oncology. He's Medical Director, Department of Hematology, Oncology, and Cancer Immunology at Charité University of Medicine, Berlin. He received his medical degree from Heidelberg Medical School in Germany. He also attended the Baylor College of Medicine in Houston, Texas, and Duke University in Durham way back in 1998. In 2008, he completed a residency in internal medicine at the University of Ulm in Ulm, Germany, after which he became an assistant professor. In 2016, he became an associate professor of personalized medicine at the University of Ulm. He also served at the Charité University of Medicine, Berlin, Germany, as a professor of hematology oncology since 2017, and is currently the director of the Department of Hematology, Oncology, and Tumor Immunology. He's also a member of the Harmony Alliance, Healthcare Alliance for Resourceful Medicine Offensive against Neoplasms in Hematology. And today, he has agreed and he has honored us by accepting to spare his time and lecture on management of AML in 2022, which will be followed by a question-answer discussion with all of you. I'll stop here and hand over the platform to him. Dr. Lars, please.
Yeah, thank you very much for your kind introduction. And it's a great pleasure to be with you here today. And hopefully we will also meet one day in person in Mumbai. Yeah, so thanks also for the kind introduction. And of course, the invitation to talk to you today. And in addition to what you have said, I also spent a couple of years doing research in the US. So I did a postdoc at Stanford and then a sabbatical at the Dana-Farber Cancer Institute, where I was mainly focusing on unraveling the molecular aberrations underlying acute myeloid leukemia. And today, but I'm happy to talk to you about AML, but mainly, let's say, from a more clinical point of view. And the idea is to also focus in today's talk on especially high-risk acute myeloid leukemia, as recently there were some novelties and changes, and we have old drugs that are wrapped into new liposomes that are more effective than what we have done in the past. And this is what also my case-based discussion will be about. So I hope that you all can see my slides now.
Yes.
If they're perfect. Okay, then I can start. I also brought some disclosures. So I hope that that the audience knows about acute myeloid leukemia. So it's the most common acute leukemia in adults. Can also occur in children, of course. And with regard to therapy, over like almost my entire lifespan, I was born in 71. Nothing really changed. We were using a chemotherapy scheme called 7+3, which is like cytarabine and 3 days of an anthracycline. Usually we use daunorubicin. And that was the standard of care for the patients who could be intensively treated. And the problem was, of course, that this went well for some of the younger patients, but we were especially doing poorly for the older patients. As you can see in the graph in the middle, that's outcome per age group. It's hard to read, but this is all what you all know, that we are doing especially poor in the older patients. In the early days, we were always thinking the problem arises that we cannot as extensively treat these patients. But what we have learned now from all these molecular analyses, that the biology of the disease really changes over time, and that many of these old patients have these high-risk acute leukemias that are just not chemotherapy responsive. Then in 2004, at least in Europe, I don't know about the dates in India, I'm sorry for that, the hypomethylating agents, azacitidine and decitabine, were approved. So 15 years ago, at least, these offered some help for some of the older patients who responded well to these hypomethylating agents, especially also leukemias with these high risk complex karyotypic changes, for example, or p53 mutations. But then more or less nothing happened, right? We still had the same chemotherapy backbone for many years until 2017, when then the first new drug was approved with midostaurin. We had a kinase inhibitor available for FLT3 mutant acute leukemia. And then it's a little bit like the Gordon's knot was cut. Then since that time in Europe, 6 additional new drugs were approved. We now have an antibody drug conjugate targeting CD33, gemtuzumab ozogamicin available. We have the old chemotherapeutic drugs 7+3 wrapped into a new liposomal formation called CPX351. Then we have additional kinase inhibitors such as gilteritinib, which we can use if the leukemia relapses. We have head-shock inhibitors, clasdegib. We have hypomethylating agents as oral formulation, which can be used for maintenance, CC486. And then recently we had venetoclax, a BCL2 inhibitor, approved in combination with hypomethylating agents, that now really became the new backbone for therapy in older patients that cannot be extensively treated. So a lot has happened during these years, and I now will show you how we are using these drugs in our hospital, and then talk a little bit more about these high-risk cases that are so hard to treat and that account for the poor outcome in many of the older patients. So what are these high-risk acute myeloid leukemias? In the past, we put them into the, or we gave them the labels that it's especially therapy-related acute myeloid leukemias, or acute myeloid leukemias that have underlying cytogenetic and molecular genetic aberrations, which we also frequently see in myelodysplasia. So it's called AML MRC, AML with myelodysplasia related changes. And as you can see on this graph, those patient cohorts really have the worst outcome based on historical data before these new drugs became available. On the other hand, we are all well aware that acute leukemias, if you have with underlying defined cytogenetic abnormalities such as translocation 15-17 with a rearrangement of the retinoic acid receptor, acute promyelocytic leukemia, or the core binding factor leukemias, where you have a rearrangement of transcription factors in AML, such as RUNX1 or the core binding factor beta. Those leukemias respond very well. You can cure many patients with chemotherapy only. In contrast, these high-risk leukemias, in the past, we really did have very good weapons, even with allogeneic transplantation. Those patients had worse outcome. And as you all well aware, in many older patients, we cannot do allogeneic transplant because they are just too old. So how are these two leukemia cohorts then really classified, or were classified in the old WHO classification that recently changed? Therapy-related AML, of course, is easy. It's everyone who has received some chemotherapy or radiotherapy in the past, who has received DNA-damaging agents. Here, it also can be often patients, for example, that were treated for autoimmune diseases and received methotrexate. You should not forget these. That cohort accounts for roughly 7% of our cases. And then, if you all remember or well aware that acute myeloid leukemia, the incidence increases with age. Over 70% of our patients are, over 50% of our patients are older than 70. And therefore, it's not surprising that a large part of these patients have these high-risk abnormalities that are linked to myelodysplasia. And in the past, that was defined as AML with MDS-associated cytogenetic abnormalities, or AML with a prior history of myelodysplastic syndrome. And you also could use morphological criteria that was multilineage dysplasia that had to be there in at least 2 out of the 3 cell lines in more than 50% of the cells. But this is now history, and we're all aware, everyone who looks at bone marrow smears or bone marrow cytology knows how hard it is to classify a multilineage dysplasia, and therefore that was omitted in the new classification of AML. And those classifications that came out recently, and I recommend highly that literature to all of you who are interested in acute myeloid leukemia, that now changes really how we classify leukemias a bit. So there is now the international consensus classification led by Dan Arbor that was published in I think July this year, where we now have a hierarchical model of classifying leukemias. If you have these recurrent genetic abnormalities, such as the core binding factor mutations that I mentioned to you, then the leukemia will be classified as AML with recurrent genetic abnormalities. If this is not given, then you have a P53 mutation, then you will be called AML with mutated TP53. That's a very important tumor suppressor gene. If that is mutant, then those patients do very often not respond well to conventional chemotherapy. And then what is also new, and you also know that very often it was hard to say whether we should treat these high-risk MDS patients with 18% of blasts in the bone marrow, already like acute myeloid leukemia cases. There was, of course, some continuancy in how the disease is developed. It's not really a black and white picture. And to account for that, the new classification allows you to also label MDS cases that were all old. In the old classification, it was MDS with refractory anemia in excess of blasts over 5% or over 10%. And you can now label these also as MDS/AML. And this is true then also for all the other categories. Then if you do not have a P53 mutation, there is now a set of 9 mutations that defines acute myeloid leukemia with myelodysplasia-related gene mutations. These are usually drivers in epigenetic regulation or genes that are linked or involved in splicing of the RNA, and you find these genes frequently mutated in patients with myelodysplastic syndrome. And we also know that these patients do not respond very well to chemotherapy. And then complex karyotypic changes are a category, but here you have to be well aware that most often those are linked to p53 mutations and would then fall into that category. There's only a few cases where you see these highly complex changes without p53 mutations. And based on cytogenetic and molecular genetic abnormalities, you now can classify most of the cases, and this leaves then very few left over who then will fall into the category AML not otherwise specified. And then in addition to the let's say molecular and cytogenetic classification, you have additional labels. If you have the history of DNA damaging drugs, then you will get therapy-related label. If you, in addition to the cytogenetic abnormalities, also have a history of prior MDS, then you get that label. And then for the younger patients, that's more important. We also have an additional label of germline predisposition, for example, RUNX1 mutations that can be inherited. And where do now these high-risk leukemias fall into? Most of them are in these new categories: AML with mutant p53, AML with myelodysplasia-related gene mutation, or AML with these myelodysplasia-related cytogenetic abnormalities, mainly complex karyotype and additional aberrations. Then the WHO classification was also revised. More or less, it shows the same thing. Here only people were a little more conservative. They sticked to the 20% of blasts necessary for defining the acute myeloid leukemia diagnosis. You do not have this 10 to 19% AML MDS cohort, but if you can see, as you can see on the lower right-hand side, similar gene mutations in epigenetic drivers and splicing genes define now also myelodysplasia-related AML, in addition to these cytogenetic abnormalities. And here we have a large concordance to the ICC. This was with regards to classification of the disease, but then of course you also have to risk stratify your patients. And here in Europe, I think also in India, or let's say worldwide, also in the US, people usually use European Leukemia Net guidelines that were also revised this year by Hartmut Döners, or led by Hartmut Döner, my former mentor with whom I trained in Ulm. And this also was published in July this year. And highlighted in red, you see the changes to the 2017 classification or risk stratification. So there's only a few changes. The most important one is on the bottom. In addition to mutant p53, we now have these 9 genes that are also in the ICC on epigenetic drivers such as ASXL1, BCOR, ECH2, those splicing genes, SF3B1, SRSF2, STAC2, U2AF1, and ZRSR2. So they are now crucial. So we also should look for them when the leukemias are newly diagnosed, in addition to these high-risk cytogenetic abnormalities, and they now define these AML cases with myelodysplasia relation. Then another new aspect which changed dramatically, or it's for me that's the most dramatic change to the past, is that the FLT3 internal tandem duplications are now completely in the intermediate group, either if you have it with mutant NPM1, that usually was supposed to be a little more favorable, or when you have it with wild type NPM1. And why is it now intermediate and not high risk anymore? Here the use of these tyrosine kinase inhibitors such as midostaurin or gilteritinib have really taken away part of the poor outcome linked to that disease. And then CEBP alpha mutations, that's another important transcription factor in myeloid cells. Here it's not the biallelic mutations anymore. Here you have to exactly look where the mutation is now located. It's now BCYP in frame mutations that define the favorable outcome group. And it turned out that almost all of the biallelically mutant CBP alpha cases have this BCIP in frame mutation, but there is also rare cases where this can occur alone, and then they nevertheless have a very favorable outcome, and you should not move forward to transplant with these patients. So how has now all this knowledge translated into our management of acute myeloid leukemia in 2022? And this is an overview of how we treat now patients in our hospital in first-line therapy, depending on whether they are fit for intensive therapy or whether they are unfit. So for patients that highly express CD33 and who have a favorable or intermediate prognosis, core binding factor leukemias or NPM1 mutant leukemias without FLT3, those are usually the ones with favorable prognosis. Here we use standard chemotherapy, and that always refers to this old chemotherapy backbone 7+3, which we now use for almost 50 years. And this is combined then with the antibody drug conjugate gemtuzumab ozogamicin. That's an antibody targeting CD33 linked to a chemotherapeutic drug calicheamycin, which is then internalized and set free in the cell, and thereby adds toxicity to the leukemic blast. Then the FLT3 mutant leukemias, either if they have internal tandem duplications or point mutations in the tyrosine kinase domain, they will get the chemotherapy standard plus midostaurin. But then for those high-risk leukemias, here it's AML MRC or therapy-related AML, we use the old chemotherapeutic drugs in the new formulation now as the standard of care. It's called CBX351. Then for the older ones, I will also talk about that a little bit in the second or last part of my talk. Here we now have the new backbone of the BCL2 inhibitor venetoclax. It's an oral compound together with hypomethylating agents. We also can give it with low-dose RSE, but in that combination, it's not approved in Europe, only in the US. And then for elder patients, and those are not so few patients that have mutations in the isocitrate dehydrogenase genes, 1 and 2, they account for 10 to 15% of the older population. We hopefully will soon have ivosidenib and enasidenib available, 2 small molecule inhibitors who in combination with hypomethylating agents also do a very good job in controlling the disease in older patients. This is already approved in the US, but not yet in Europe. But now let's focus on the high-risk acute myeloid leukemias, those with these myelodysplasia-related changes. Yeah, I told you that we now have CBX351. That's basically the old drugs, cytarabine and daunorubicin, put into a new package or nicely packed in a liposomal formulation where you have a fixed molar ratio of 1 to 5. And what do these liposomes now really do that the drug becomes more potent? The new compound or the new drug really has new pharmacokinetics and pharmacodynamics. The half-life is much longer because you have a lower first pass effect through the liver. And then the liposomal formulation also ensures that the drug gets much better into the bone marrow niche. And therefore, the ratio on the leukemic stem cells is much higher. And that explains why even those leukemias who were in the past not so chemosensitive can now be more aggressively treated with that new drug. It was approved in the EU for the treatment of adults with newly diagnosed therapy-related acute myeloid leukemia or AML with myelodysplasia-related changes, and also in the new guidelines, in the ELN guidelines, CBX351 is the recommended treatment for those cohorts if they can be extensively treated. So the question is also always what is important to patients, and I think you're also all aware that the involvement of patient advocates also in the design of new trials is becoming of growing importance. And this was a very nice study that was still led by Eli Estey, who recently died, unfortunately. a very well-known researcher on acute myeloid leukemia in the US. And in that retrospective study, looking at 11 large centers in the US, they asked patients, both younger and older ones, even the ones who could not be intensively treated, what would be the primary goal of outcome, whether it was cure or whether it was also quality of life, even though they would not be cured, but perhaps live longer with better quality of life. And interestingly here, almost all the patients, 82% of the ones who are intensively treated or younger patients, but also the older, for 69 of these patients, 69% of these patients, cure was the primary goal, and they didn't really care so much about the quality of life or the risk that they would undergo with a let's say more intensive therapy of dying due to toxicity if cure was the goal. And with that regard, we now really carefully evaluate whether patients can be treated more intensively, especially if they are around 65 or 70 years, because you really can cure more patients with more intensive therapy. And this is the data that has led to the approval of CPX351. Recently, there was a publication on 5-year long-term follow-up data, and you can see you really achieve a plateau. It's around 20%. That's, of course, far from being optimal. But for these older patients in the past, we didn't really have a good option, and only the few who responded to hypomethylating agents or the few who could be moved forward to transplant could survive. But here the new drug really doubled outcome in a randomized phase 3 trial, which is, in my opinion, very promising data, and therefore also definitely justifies the use of that drug. And why is this more effective, and why do we use it? It's especially important for the patients who can be moved forward to allogeneic transplantation. And this is the curve for the patients who underwent allo transplant. And in this high-risk cohort with these myelodysplasia-related changes, if you can get them in complete remission with this intensive treatment approach, and you can move them forward to allogeneic transplant, then you suddenly can cure 50% of this high-risk cohort. And if you are well aware of the numbers or the controls in the past, here we only could cure around 20% of the patients, even with allogeneic transplantation. And this is really amazing for this high-risk cohort. And here, CPX351 also does better than the let's say, low intensive therapy or less intense therapy that recently was approved as a hypomethylating agent in combination with venetoclax. But I will allude to this then in the last part when I talk about venetoclax. And what is the reason? Why do we do better in that drug? I will come to that in a minute. Most importantly, if you compare CPX351 to the conventional chemotherapy, the old 7+3 scheme, you can see here which is shown on the right. You can see here that CPX351 is not really worse with regard to side effects. It prolongs a little bit the thrombocytopenia and neutropenia duration, but most importantly, this is not linked to higher early death rates. And therefore, as this is a sign for better control of the disease, that translates into this improved outcome. Then I also brought some real-world evidence data from CPX351. We all know that very often in randomized phase 3 trials, cohorts are usually younger. They are not so poor off with regard to their ECOG status. And therefore, usually when we then use these new compounds, we once in a while are surprised that they do not do as well as we would have hoped. But for CPX351, this is really not the case. There is data now from Germany, from France, and from Italy, who have all looked in over 100 cases. And you can see here high complete remission rates if you use it for induction therapy in over 50%. And if you then can translate that high complete remission rate and into good consolidation with regard also to allogeneic transplant, that means that you really can improve overall survival in this high-risk cohort, very well. And this is, of course, not randomized data. It's retrospective analysis of multi-center cohort. So you have to look at these curves with caution, of course, but nevertheless, I think they were very promising for these high-risk leukemias. And it also looks like you can achieve a plateau in all these countries. So that definitely also is an additional reason for me to use that drug wherever possible. And from the German group, a nice colleague from Essen, Thomas Schröder, provided me with that slide where they now also did some update on their transplant cohort. And here the data look even better than in the phase 3 trial that led to the approval of the drug. Here the median follow-up is not even reached. And you can see that the 1-year overall survival is still in the 70% range. So that means to me that even if we have longer follow-up, it definitely should not go below 50%. And that's really encouraging results for these high-risk leukemias where we really didn't have anything in the past. And what is the reason? Why do we think this is working so much better than what we have done in the past? As you have this higher concentration and you get it better into the bone marrow niche, you get more patients controlled that well that they really then can get the benefit from the new immune system when you transplant them. And here you all know that controlling the disease well, going into transplant without measurable residual disease is crucial. And colleagues in Italy, France, and Germany now also have looked in the available samples where they could look for MRD. And it turns out that roughly in 1/2 of the patients with a new compound, you can achieve really MRD negativity. And then if you consolidate with the transplant, those patients really have the highest benefit. But of course, if you cannot move forward to transplant, those patients, I didn't show that slide today, but those patients, of course, also have a survival benefit over the ones who are treated with conventional care. But really the goal should be to move forward to transplant. And now we come to the case I brought to you. This was a 64-year-old male patient who showed up in our hospital in April this year. He presented with tree lineage cytopenia and had in the bone marrow 45% of blasts. Then also what we very often are facing, that in these MDS-related patients with often also complex karyotypic changes, we cannot do cytogenetics. Here we are currently developing new approaches with benchtop sequencers where you can do that then overnight. That also would be something I could talk to you in one other lecture. And then in addition, of course, we do molecular genetics. And here you had 2 mutations that would now qualify that AML as higher risk according to the new ELN 222 guidelines. But then the problem was in that patient, he had a rectal carcinoma 5 years ago. That was an early stage, but nevertheless, he had received surgery for that. And then, no, he didn't get surgery. Sorry, he received combined radiochemotherapy to treat the disease. Therefore, he definitely qualified as therapy-related AML. And then, based on the combined radiochemotherapy, already had developed a secondary myelodysplastic syndrome in August 2019. At that time, normal cytogenetics, but the MDS-related mutations were already present. And at that time, he qualified for a trial with a TIM3 antibody, MGB453, that was given in combination with a hypomethylating agent, azacitidine. But now in April, he then, of course, now presented to us with definitely clear-cut AML with myelodysplasia related gene mutations. He had 2 of them. and he gets these extra labels if you look at the ICC therapy relation and prior MDS. And with regard to the current risk classification, he definitely is a high risk acute myeloid leukemia. But now what would you do? Yeah, this 65-year-old patient had already 2 cancers prior to the AML. Is he really fit for intensive therapy? But other than the rectal cancer and the MDS, he only had some hypertension that was well controlled, only had some minor surgeries in the past. And the ECOG of 2, in our opinion, was mainly related to the symptoms of the acute myeloid leukemia. So we talked to him, and like for the other patients I had mentioned in one of the previous slides, he definitely wanted to be cured. He said, I already survived 2 cancers. I also want to survive the 3rd one. So we moved forward and, not surprisingly, induced him with CPX-351. That more or less went well. He had what is known for the drug, more prolonged neutropenia, during which he had some urinary tract infection that could be controlled without problems. And on day 21 bone marrow biopsy, and then again 3 weeks later, he was blast-free and in complete remission. We then consolidated him with CPX-351 and then moved forward to allogeneic hematopoietic stem cell transplant, which he received from his identical sister. We did a reduced intensity conditioning using treosulfan and fludarabine together with ATG, and did the standard GVHD prophylaxis with cyclosporin and MMF. I can't pronounce it this morning. Mycophenolate. Yeah, that's it. And he went through the transplant without severe complications so far. Has no acute GVHD. Is still in complete remission. And what we have done in the lab, that's still not routine, but we are also currently developing NGS-based approaches where we can use the entire panel that we use for diagnosis, also use the same panel for follow-up. And you can see here that with the initial diagnosis, he had in bone marrow blast was 65%. The percentage of cells carrying the mutation was even higher. But past induction, the load of tumor cells was declining rapidly, and prior to consolidation, he was already what we would call MRD negative, and he stayed MRD negative, went into transplant. And you, as I already told you, this is what we think the most important factor in guaranteeing that the new immune system has enough time to develop its function and control the remaining blasts. And with that, we sincerely hope that this is also one of the patients that can be cured by that, or is cured by that new approach. So with that regard, just a few words with regard to measurable residual disease. I think this is becoming more and more important. I think with NGS-based technologies, this also becomes affordable, can be done in major labs with expertise. I think in the future, we should not only follow the well-established markers, but we should look at all the genes that are there. There is some of them, such as the ASXL1 I just presented, which is frequently linked to clonal hematopoiesis. So it also can stay up, and nevertheless, the patient can be in complete remission because the leukemic clone is gone, but the clonal hematopoiesis clone is persistent. But it turned out that in this patient, in our patient, the clonal hematopoiesis or MDS-related clone was identical to the AML clone. And all of these cells had the transforming event. And if then the marker goes down quickly with chemotherapy, you only have normal hematopoiesis coming back, then of course you can also can use these clonal hematopoiesis associated markers for monitoring measurable residual disease. And this is where we stand today. This is still the standard. Usually it's done for nucleophosmin-1 mutations for core binding factor AML. Usually MRD is measured with quantitative real-time PCR, or you do it with flow cytometry. Advantage here is you can do it for all patients. Here you need these special markers. I think in the future, if we look at all the genes that are linked to AML, And if we use panels for doing the the MRD measurements, we can define many more patients in whom we have a marker to follow up. And that becomes more and more important, especially if you think of markers such as FLT3 mutations or IDH mutations that also have therapeutical consequences, that you can monitor these over time. And when should you do the MRD? Usually we, of course, evaluate the patient at diagnosis, then we look after induction therapy, then at the end of consolidation or before you go into transplant, and then afterwards you also should follow up the patient more tightly at the beginning, and then if he stays in CR and is MRD negative, then you can increase the time frames. But now we come to the last part, which is shorter, so don't be worried. I'm close to my final slides. To the fact, how do we make the decision who is fit for intensive therapy and who is not? And there is some frailty indexes, we have performance scores, you can do a lot, but I think for me, most important is your personal experience and your gut feeling. And if the patient tells you that he was very fit, he was doing sports prior to the onset of the leukemia, was very active, and has, let's say, few other diseases that prohibit you from treating him intensively, and if the will is really to be cured, and also an allogeneic transplant would be an option for the patient to consolidate the disease, then we usually really try to move forward to treat them intensively with these new approaches using, for example, CBX-351. And we favor that in especially TP53 mutant high-risk leukemias over the new option, which we now have for older patients, the combination of azacitidine with venetoclax, as both regimens are equally doing well with regard to achieving CR rates. CR rates for these high-risk leukemias with venetoclax also in the 50% range. But here, patients relapse much faster, and you do not get these high numbers of MRD negative disease controls, and therefore you can move forward with fewer patients to transplant, or they relapse early, and then you don't have a very good option in second-line therapy. So again, if you can treat these patients intensively, because most of the symptoms are leukemia-related, I would give it a try. And with this, we come to the guidelines for these older patients. I told you azacitidine and venetoclax is now the new standard. Low-dose RRC in combination with a Hedgehog inhibitor Clastigib does not really perform or is not widely used in Europe, especially as the data is not as good for azacitidine and venetoclax, but might be a good option for patients who cannot be treated with hypomethylating agents, especially as the combination with venetoclax is not approved in Europe. So here we come to the second case, an older patient, again, 73-year-old female patient, also newly diagnosed leukemia, who showed up with acute myeloid leukemia with myelodysplasia-related changes in January this year. In this patient, as I had told you on the previous patient, we couldn't do conventional cytogenetics, but here I brought you one of the plots. This is a low coverage whole genome sequencing using a new long read sequencing technology called Oxford Nanopore sequencing. That's a benchtop sequencer, and you can do this low coverage whole genome overnight with little hands-on time. So this is what we now routinely do on all the patients. And here you can see that looks like the old SNP array profiles, all the chromosomes from 1 to 22. You have the copy number plotted, and you can easily see that this is an highly complex karyotype. In addition, molecular genetics showed P53 mutation. So according to ELN 2017 and 2022, that's definitely a high risk AML. And the question is now, what do we do with this patient? Here, the story was different. Even if the ECOG was not as bad in the other patient, the patient was also prior to onset of leukemia, not very healthy, had not very well controlled diabetes, was obese, hypertension, cardiovascular disease, had a myocardial infarction in the past. And we really felt that that patient would not really be fit for CPX351. Therefore, we used venetoclax, which of course is also a viable option in these patients. It's a small molecule inhibitor that targets BCL2. BCL2, it's an anti-apoptotic protein that's upregulated in leukemias, and thereby binds pro-apoptotic proteins such as BIM, and then the apoptotic cascade cannot start. If you then treat these patients with venetoclax, BIM is released and the mitochondrial cascade is started, cytochrome C is released, and the leukemic cells can undergo apoptosis again. And in a randomized phase 3 trial, this has also significantly improved overall survival in these older patients and now has become the standard of care. But the problem is, and this is what I wanted to show you at the end, that especially these P53 mutant patients that are shown here in red and in purple. The purple ones are the ones who received the new combination with venetoclax. The red ones are the ones who received the previous standard of care, azacitidine alone. And you can see that you cannot improve outcome in that cohort with the combination. And the reason is that they relapse so quickly, even though if you receive a CR. And therefore, we really try to treat these patients, if possible, with CPX351. But the problem is, of course, many of the older ones you cannot treat extensively. And here we hope that in the future, we really get new treatment strategies, new compounds, such as, for example, antibodies that are also targeting new immune checkpoints, such as CD47, that's a don't eat me signal that stops macrophages from attacking the leukemic blasts. And here magrolimab, a new antibody, might be a promising option to be combined with venetoclax and azacitidine. And this was data presented at last year's ASH and follow-up data shown at EHA this year. And that combination shows promise that you also can then, if you have now this immunological component also in the treatment of older patients, can also overcome the resistance that's frequently developing in P53 mutant leukemias. And with this, I'm at the end. Sorry, I talked a little longer than initially planned. I think we have many new interesting drugs, especially for the high-risk leukemias. Things are moving now forward. And I also showed you the new guidelines, which I highly can recommend to all of you. And with this, I'm now really at the end, and I'm happy to take your questions. Thank you very much.
Thank you so much, Dr. Bullinger. That was fantastic. Within about 35-40 minutes, you have given us glimpses of what is really new. You gave us the most modern classifications, the ICC, the WHO, the ELN, and you also sort of elaborately discussed the drug CPX351, not a very popular drug on this part because of its non-availability, and a bit of less knowledge also because of the same reason that first-hand information wasn't available for most of our friends and colleagues. But what you showed today, I'm sure that the use of this will pick up on this side quite a bit. And it was fascinating. Your two cases, everything was fantastic. You took us through this journey extremely well. Before I ask our colleagues to put questions to you, to the audience, please put your questions in the chat box. Also, all of you, those who are willing to open your videos, you can open your videos. That will be, very, very interactive, and the ambience will be much better. And then let's take questions. So please use the raise hand sign. We'll go in the order in which you put up the raise hand sign. Deepak, start your question.
Thank you, sir, for that wonderful education. My question is regard to a young fit male with an inversion 16 AML and an exon 8 KIT mutation, the presenting WBC count of 1.5 lakhs. Post-induction, what would you be strategy? Will you be considering this patient for an upfront transplant? Is it based on the MRI?
So the quality was really bad with regard to the transmission, but let me summarize. So it was an inversion 16 patient with a KIT mutation. And the question would be how to consolidate after induction therapy correct?
And with a presenting WBC count of 1.5 lakhs.
Very high.
Sorry?
Presenting WBC count of 150,000.
At the initial diagnosis, yeah. Yeah, this is a very good question, or also a hard one to how to decide. I mean, officially it's low risk, right? And you would not have to move forward to transplant. But we all know that roughly 1/3 of these patients relapses within the first year. And colleague of mine, Frederick Damm, has done a large trial in a similar cohort with 821 and inversion 16 mutations. And that study clearly showed that FLT3 mutations and KIT mutations provide a poor prognostic impact in that cohort. So what we usually do, as KIT is also responsive to kinase inhibitors, we combine it with dasatinib. We have a clinical trial where we put these patients in, and then we decide based on how fast MRD levels go down. If they really respond very well and get MRD negative, then we do not move forward to transplant and have this dasatinib maintenance. If they do not go down quickly and they do not get MRD negative, then we would transplant them. Yeah.
Thank you so much, Dr. Deepak. I also request all our colleagues to ask one question at a time, and we'll come back to you if you have more questions. Dr. Roshni.
Good morning, sir. I really enjoyed your wonderful insights. I had two questions regarding the doses. One is the dose of Ara-C 100 milligram per meter squared versus 200 milligram per meter squared. Which patients? We are more comfortable with 100 milligram per meter squared.
Yeah, so that's also depending on, I think, where you were trained. There's different philosophies, but we usually do 100. So I think 100 is fine. Yeah, you do not necessarily need the 200.
Are there any subsets where one would use a 200 milligram per meter squared?
There is no, I mean, of course, in younger with more aggressive disease in the past, you felt more comfortable. But I think I think the effect really comes from this continuous infusion. And so the dose at that stage doesn't really matter so much. I mean, similarly to like also consolidation, where in the past we thought we really have to give 3 grams a day. Right, we now know also that 1.5 grams per day in younger ones is sufficient. Yeah, but of course, if it's more aggressive, younger patients, you can do 200. If you feel more safe, you definitely do not do anything wrong. But we usually go with 100.
Same thing for donomycin 60 versus 90. 90 in which patients?
But I think, there is, according to my knowledge, there is clear data. I think the Dutch group has shown that, for example, that with 90 you only get more toxicity. Usually we do not go over 60. We always stick with this intermediate dose of anthracycline.
Thank you, sir.
Thank you, Roshni. And if you have more questions, we'll come back to you. We'll take one question from the audience. Dr. Arihant Jain wants to know, he has a young but unfit patient, and because of his unfitness, he has induced this patient with azacitidine and venetoclax, just as a bridge to go to the high dose cytosine albinoside or intermediate dose cytosine albinoside once he becomes a bit more fit, and then achieve the CR or PR, awaiting for the transplant. Do you agree with this philosophy?
Yeah. Yes, this is what we do once in a while too. I mean, officially you have to say that's of course off-label, if you would put it like that into the discharge letter, right? Because then if as soon as you think one time he could really become fit for intensive, I mean, we have to be very careful, because otherwise we might not get reimbursed for the azacitidine venetoclax. But we frequently do that, especially in the older ones, where you think, okay, now I just cannot do 7+3 or CPX-5/1. I'd rather start with this, let's say, less intense therapy. We also did that, for example, during COVID, when hospital beds were rare. But then I think it's very important, and this is a very good question with that regard, that with venetoclax, the combination, we get many more patients into complete remission than in the past. And then many of them really will, it's a little bit like phoenix coming out of the ashes, right? Especially if the problems were leukemia related, they do then suddenly very well after achieving the CR. And then you definitely should also try to intensively consolidate them with a transplant if possible. Yeah.
Thank you so much, Dr. Smita.
But usually, sorry, one comment. I mean, if they respond very well, usually we then do not do HiDAC or IDAC, or the high dose RSC, but we'd rather move forward to transplant immediately to save the toxicity. Yeah.
Absolutely fine. Yes, agree. Smita from JIPMA.
Yes, sir. Thank you so much for the talk, Dr. Bullinger. It was very educative. I had the similar question which sir had asked from the previous audience, that many a times because of our patients presents with baseline pneumonia, we have a high mortality during induction because of the gram-negative sepsis, resistant infection. We end up giving azacitidine venetoclax to these patients, reassess their fitness after 3 to 4 weeks, and then plan for the consultation. So as you suggested, should we go back to the intensive, proper 3+7 after the aza venetoclax, labeling it as some pre-phase, and then go to consultation for transplant depending on the donor availability or high dose cytarabine? And
yeah, I mean, if they respond well to the combination and get into a CR, then we rather continue that and then go for transplant rather than adding a high dose RSC. But I think for that combination, it would make sense for me if, let's say, because venetoclax is so expensive, right? You don't want to give it for a longer time. But other than that, there's few data, right? And therefore, we'd rather stick with continuing what has worked in the first run, right? And then saving some toxicity, and then rather go into the transplant. But with regard to infections, at least in our hands, the combination of venetoclax and azacitidine is not really much better than intensive therapy, especially if you have these prolonged neutropenias. And if you start, I mean, we usually have to use it in the dosage in which it was approved, and I think this is just too high for most of the patients. So, I mean, for many older patients, I think 2 weeks would be enough. So what we do is we quickly look into the bone marrow really after 4 weeks, and if all the blasts are gone, then we already reduce the dose for the second cycle. Yeah.
Thank you.
Thank you for sharing that the infections are equivalent in aza venetoclax, which is our experience also. Just one more query, if sir allows, is will you recommend use of addition of venetoclax to standard 3+7 for fit patients to improve the CR rate from the standard 3+7?
Yeah, I think there is now a trial ongoing in which we participate, where we will also put venetoclax in combination with this intensive therapy, where we now use it still off-label. It's in relapse. I didn't talk about like relapse chemotherapy, salvage chemotherapy. Usually we use FLAG-IDA in our hospital, and we add venetoclax to FLAG-IDA, and we call it Flavida. Yeah, but there it's given for 1 week together with the salvage chemotherapy, and that's really helping a lot of patients.
Okay, thank you so much.
Thank you, Smita. We'll come to Dr. Anupama. Before that, I'll take one more question from the audience, which you have partly touched. In c-KIT mutated AML, do you always add dasatinib to standard induction?
Yeah, always is. It's in our clinical trial, in that we do it. If a patient cannot go into the clinical trial, we ask the insurance companies whether they would cover it, because we have good data that can improve outcome in these patients. And then if it's approved, we add it. If it's not approved, then of course we cannot add it. Yeah, because it's not as expensive as other kinase inhibitors, but yeah.
So you at least prefer it in every case. Okay.
Yeah.
Dr. Anupama Jagya, yes.
Thank you, sir. Thank you. That was a very nice talk, especially it demonstrated a lot of points like, about using the newer agents. Now, I was just a little curious because we often, we really struggle with D-cytabine as a hypomethylating agent, especially in our elderly AML. So we tend to use more of azacitidine. What is your experience like in Germany?
Yeah, this is also a very good question, and I think there's many debates which is the better one. I think it doesn't really make a difference, and we usually also use azacitidine. Yeah, I think they are equally potent from all the data which we have obtained so far. Yeah.
Thank you. I was just curious.
Yeah,
Thank
so
you.
azacitidine is fine. Yeah, so we will see in the future that there is now, we now have oral azacitidine for maintenance. That's definitely different with regard to pharmacokinetics and pharmacodynamics, but I think there will be now also an oral decitabine coming out. And of course, that then would be a valuable combination partner. If you could do that with venetoclax, then you would have a fully oral therapy for older patients. That could then become an option.
Thank you.
Thank you, Anupama. We will come to Dr. Verma, and once again, before Dr. Verma, we'll take another question from the audience. Last question was, I forgot to name, it was from Dr. Akhil Rajendra. Now the next audience question is from Dr. Ashish Verma, which is almost similar to what you just mentioned. It is related to elderly man with ECOG 1 to 2, complex cytogenetics. And this person was then treated with azacitidine injection and achieved complete remission. And he wants to know whether he can now put on oral azacitidine maintenance.
Yeah, this is a good question. I think we do not have really good data with that regard. But on the other hand, if you think like, oral azacitidine definitely has shown effect in maintaining the remission, right? It does so in high-risk leukemias. It does very well in NPM1 mutant. And if you now think of azacitidine as a CR-inducing therapy, then of course you can also use oral as maintenance. But usually it's not approved in that sense. So the reimbursement would be very difficult in Europe, and I would not change a running system. That we have the same problem that people just do not want to come anymore, right, after a time. But usually if you change it, then relapse comes quickly. So I would try to convince the patient to continue with what has worked in the past.
Right. So the message is, if possible, continue the injecting. Oral is different from what you do. Dr. Verma, your question.
Thank you, sir, for your nice talk. Just wanted to know regarding the toxicities of azavan. So we see that our patients have persistent cytopenias throughout the month when we use aza with venetoclax. So like, how do you manage this cytopenia, and how much it takes cytopenias to recover? Do you change the protocol of venetoclax maybe 15 days a month, or 14 out of 28 days, something like that? Because I've seen 2 or 3 patients, they are not recovering at all throughout the month. They have persistent thrombocytopenia requiring multiple transfusions.
Yeah, this is what we also see in many. So I think definitely it's important that you do the bone marrow to see whether the low counts are really due to the complete response, or whether it's persistence of disease. Of course, if it's persistence of disease, we continue with a full dose. But most often it's these patients that respond very, very well, but where you most likely have overtreated them if you did it according to the label. Then we use GCSF definitely. There is good data that you do not do anything bad to the leukemia part. And then of course for the second cycle, especially if it's this very long neutropenias, we definitely only give 2 weeks of venetoclax. So we really go down dramatically with the dosage already for the second cycle, and not only after the second. Yeah.
One more question.
And usually what we also do, as of course, this is, I'm not sure whether the drug companies are listening to these, but at our hospital, we have many construction sites. So also in the older patients, even if it's not intensive, we are afraid of fungal infections. So all of our patients get posaconazole prophylaxis, and with that we only give 100 milligrams of venetoclax, so that the nice effect, if it also saves some costs.
Sir, all intermediate risk patients you push for transplant, or is any?
Yeah. If possible. So we have a healthcare system that pays for that, and yeah, usually we try to move forward to transplant. Yeah, unless the patient doesn't want to, or yeah.
Thank you.
Thank you, Dr. Verma. We'll come to Dr. Gopinathan after one more question from the audience. That's an interesting question Dr. Arihant Jain has put. So he has a patient of dyskeratosis congenita transformed to acute myeloblastic leukemia. Unfortunately, the only prospective donor is haplo mother, and she's also a heterozygous dyskeratosis mutation positive. She's asymptomatic at the age of 50, and can he use this mother as the donor for the transplant?
That's a tough question. I mean, that's definitely not optimal, right? But if there is no other option, I think it's better than not to transplant. But I would rather go for someone without carrying the mutation. Yeah.
Right.
Yeah, that's all.
So we go to Dr. Gopinathan. Gopinathan is our brilliant student. He just got gold medal in his postgraduate exams in hematology.
Oh, congratulations.
Thank you, sir. Thank you. Thanks for the very informative talk, sir. Sir, I have a 46-year-old fit female who's a FLT3 positive AML, and she present with upfront CNS positive disease. So what would be the ideal induction strategy, and how do we address CNS disease in her?
Yeah, CNS disease is always problematic, right? We definitely would treat her with, first line would be, of course, the standard 7+3 plus a kinase inhibitor. We know that in ZNS disease, those kinase inhibitors, they also go into the cerebrum. And in addition, we would, of course, give her, for the CNS involvement, local intrathecal chemotherapy. And then, I mean, it depends whether you can control the disease. Usually that's functioning quite well. And high-dose RSC for consolidation, and is also helpful, as high-dose RSC will also help with the CNS involvement. Then the question is, of course, how do you move forward with transplant? If that patient is transplanted, do you then still, in addition, do a radiation therapy for the neural axis, right? This all depends a little bit how well you can control the disease, how good it responds, and yeah, also what the patient wants. But usually we try to do it because we are really afraid of CNS relapse.
Sir, intrathecal therapy, would you advise to do during induction when she has circulating blasts, or can we place it during consolidation? Like, what would be the ideal time point to?
Yeah, usually we try to reduce the blasts quickly. That's what we usually already do with hydroxyurea, right, at the beginning, until we have the molecular and cytogenetic information on FLT3. But I would start, if the symptoms are not that bad, then I would start doing it after you are through with the induction, because before she really becomes very neutropenic, and then but then most of the blasts should be gone. And if she already has CNS involvement, I mean, then you also do not really have to be that afraid that some additional blasts might get into the CNS through your intrathecal puncture. Yeah.
Thank you.
Thank you, Gopinathan. So we will be coming to Dr. Upendra, but again, taking a question from the audience. What is the maximum dose of venetoclax you use when you give it in combination with posaconazole or voriconazole?
And then we use 100. Yeah, there are some studies that say you can even go down to 50, but we usually use 100, as we are afraid that it might not work if we use too little. Yeah.
Right.
But usually we do the normal ramp up until 400, and then we start with posaconazole, and then we go down to 100.
Right.
Yeah.
Thank you. Upendra, go ahead.
Thank you, sir. Thank you, Dr. Lars, for that wonderful speech on AML. So we have some patients, say young patient AML with FLT3 ITD, low allelic burden with NPM mutation positive. So initial NCCN guidelines place this patient into a favorable risk. Those patients with high allelic ratio more than 5.5 and NPM mutation into intermediate risk. So how do you treat those patients with low allelic burden and high allelic burden with NPM mutation?
Yeah. So the old ELN classification put those, as you said, in the low risk group. But here also the philosophy was different regarding to the centers you were talking to. I always thought that the presence of a FLT3 mutation is bad, right? Even if you have a small clone, which then might become resistant and cause relapse. So we in our center also try to transplant these patients if they agreed, even if they have had these low allelic burden clones. And this is what we still try to do in younger patients. Yeah.
So where do you place these patients, into low risk or intermediate risk with low allelic burden?
It's intermediate. Now the new classification doesn't really account for the ratio anymore. The presence of FLT3 ITD is now irrespective of the ratio intermediate risk.
So but NCCN guidelines still place these patients into low and intermediate risk.
Oh, no, the ELN 2022 puts them in intermediate. Yeah.
Intermediate.
Yeah.
Okay, thank you, Upendra. And before Akaksha, we'll take one question from the audience. Last question was from Dr. Arihant Jain. This one is from Dr. Ashish Verma. He's got a 27-year-old young man, no comorbidities, ECOG 0, cytogenetics normal. The AML panel is NPM1 positive with FLT ITD low allelic ratio. He induced remission and the MRD was 0.2. Patient refused to. Dr. Anaiza, please mute yourself. Anaiza, please mute yourself. Okay. So this patient has a MRD of 0.2. He refused to undergo bone marrow transplant. So he received 3 consolidation. He wants to know now maintenance with midostaurin or oral azacitidine.
That's also a good question. Yeah, so if the FLT3 clone is gone, I would continue with midostaurin. Yeah, but there is no randomized data on that. But if it was part of the induction therapy and helped to control the disease, I would favor to continue with midostaurin. Also depending, of course, how well the patient tolerated midostaurin. Some of the patients do not tolerate it well. If that is the case, then I would rather than continue with azacitidine, with oral ASA than with nothing. Definitely those NPM1 mutants, they also, that was the subgroup analysis published by Hartmut Döhner, they have this highest benefit from oral azacitidine maintenance also. But my first choice would be continue with midostaurin. If the patient doesn't tolerate, switch to oral ASA.
Right, sir. Dr. Akanksha.
Yeah. Hello, sir. Thank you so much for the excellent talk. I'd like to know that, in patients who have germline predisposition, when they are planned for allogenic stem cell transplant, do you screen the donors also for the same?
Yes, we do. A short answer. Yeah.
And so your
for example, we had, for example, a family with RUNX1 mutant leukemia, which is one of the markers that, and we already had treated the father at the age of 40, and then the son showed up at the age of 22 with an AML. and the brother already also had some platelet problems, and he also was carrying the RUNX1 mutation, and there we definitely would not use the brother as a donor and try to look for someone unrelated. The question is then, if you now have more and more older patients which we are transplanting and use relatives there, whether clonal hematopoiesis is a problem, if that is present in the transplant. And here we have done a large study that there it doesn't really, the risk of a transplant-related leukemia is a little higher, but it's not very high. But on the other hand, the inflammation, the inflammatory component which you will receive when you get a transplant with clonal hematopoiesis is controlling the disease better. So the relapse risk is going down. So in older patients, we do not look for clonal hematopoiesis as that is not having a poor impact on the transplant.
Thank you. Thank you, sir.
Thank you, Akanksha. Another question from the audience. Dr. Jaswintini wants to know, what is the role of CLAG, cladribine-based treatment in AML? Which subset of patient do you choose that?
Yeah, so there's some really like cladribine as a chemotherapeutic drug. We usually only use it in clinical trials, more or less. So I'm not a huge fan of it, but I think it all depends a little bit on where you have trained, what experience you have with the drugs. So yeah, we do not use it very often, but it's definitely a viable option in some patients.
Thank you. Radhika, go ahead.
Thank you, sir. Thank you for the presentation. My question is, I have a young, fit lady in her 50s, diagnosed acute myeloid leukemia, FLT3 positive, NPM negative. I induced her with donor-resistant cytarabine along with midostaurin. Post-injection MRD is negative. So we have counseled her for a transplant. In the meantime, like we bridged her with some HiDAC along with midostaurin. She did some research from Google searches and all. Now she defers a transplant. She has gone through some searches which shows high morbidity, mortality and all. She doesn't want to go for transplant following this consolidation. So can I consider an option of give 2 more consolidations and take her up for midostaurin maintenance for 1 or 2 years? Is that an option here?
Yeah, this is what I would do then if the patient does not want to get transplanted. Yeah, exactly. Yeah, and I also, like in the other case, I would continue with midostaurin as maintenance and not with the oral azacitidine. Yeah.
No, how long will you maintenance? 1 year, 2 years, or like how do we?
Oh, how long? Oh, usually, as I said, with midostaurin, that usually terminates itself after 1 year, most likely anyway, because the patient does not want to take it any longer. If he tolerates it very, very well, I would also make it a little bit depending on the MRD. If you can measure MRD for FLT3, or you have some other marker, if he was completely negative all that time, then you might stop it after 1 year. If there was like some ups and downs with values once in a while being mildly positive, then I would rather continue.
What are the comparative responses, sir, between midostaurin maintenance and I mean, are they equivalent? But it's inferior. The maintenance is inferior.
Sorry, I didn't get the question because there was too many.
Radhika, repeat your question. We couldn't get it.
Yes. No, what is the comparison between? I mean, what are the outcomes? Comparison of outcomes between this midostaurin maintenance and an allo transplant. I mean, the maintenance is too far inferior.
Oh, no, yeah, allo transplant is definitely what you should favor. I think this has the RATIFY study has clearly shown that led to the approval of midostaurin, that you also have the largest benefit in the patients who undergo transplant. Because this is what we know, that these kinase inhibitors, they do a good job in controlling the disease better and perhaps also getting more patients into MRD negativity. But then many of the patients will relapse. They will develop resistance to these kinase inhibitors. And we have done a nice study where we looked especially at patients relapsing during midostaurin treatment. It was published in Blood last year. The problem is that you either can lose the FLT3 mutation or you can get resistance mutations that are downstream of FLT3. So you still have an effective inhibition, but you activate RAS further downstream, for example. Or what we also see, completely independent relapse mechanisms. So that means that FLT3 is still controlling the clone, but that something else comes up that has a different driver. So if ever possible, I would try to convince the patient to undergo transplant.
Thank you. Dr. Buligar, I will go on and on, but at any stage you feel like logging out, stopping us, please tell us.
Oh, that's fine. It's fine. I'm awake now. That's fine. I think I have until 10:45 or so I can do. Yeah.
Okay, that's fantastic.
No, not 10:45, 9:45. Sorry.
Okay. Dr. Priyanka will come to you. And again, I'll take one question from the audience. Do you practice day 15 marrow in a patient who is on 7+3? From Dr. Arihant.
Yeah. So in my old hospital where I was trained, we didn't do it. In Berlin, where I'm now working, they always did it. So I said, okay, I don't mind. If you want to do it, you can do it. And there is some prognostic information in that. If you have still a full bone marrow at day 15, that's not good. Then you already should think about some other option. And if it's cleared of blasts, then that's prognostically very good. Yeah, so we still do it.
Thank you. Yes, Priyanka, go ahead.
Thank you, sir. Thank you for the crisp update. So this is regarding a patient who is AML, young male, but presented with fungal pneumonia at the outset. We started with Aza-Ven, and then after that, he did not have much of finances to continue for 7+3. Given second dose of Aza-Ven, post second cycle of Aza-Ven, the patient is MRD negative. Patient does not still have much of finances to undergo for a transplant or for the 7+3 followed by a consolidation with HiDAC. So what is your opinion regarding if this patient is MRD negative post 2 cycles Ven and Aza, any role of HiDAC consolidating with 3 cycles directly, or do we post again for a 7+3 and a 3 cycles HiDAC after that?
Yeah, this is a little bit like what we have discussed earlier already. In these patients, we would rather, I mean, I'm not sure about how the insurance and the financial thing will, but the problems will be there, but we would rather continue these patients on the combination Ven-Aza, and then rather give that for at least a year and then perhaps stop, and then wait for relapse and then treat intensively if that's then still an option. But I think there is few data that the consolidation with high dose RRC after an induction with Ven-Aza will be more beneficial than continuing the patient on that. Yeah.
Thank you, sir.
Thank you, Priyanka. Another question from the audience. This one is related to when do you assess the response to treatment when patient is on Aza plus venetoclax, after 1 cycle or after 2 cycles?
Or definitely after the first cycle, because you have to be sure whether the combination works and whether you have the cytopenia due to perfect disease control, because then you can rapidly reduce the dose, or whether it's still persistent disease, and then of course you would not pause the treatment and you would directly continue with a second cycle. So we definitely look into the bone marrow in all the patients after 4 weeks.
Thank you. So from the faculty here, we have Dr. Sanyal, who hasn't asked any questions so far. So Sanyal, go ahead.
Yeah, thank you, Dr. Lars. I have one question totally from patient's perspective. The patient who received Aza-Ven and they got a MRD negative after the induction, and when they're back in the clinic and if they are transplantable, my life is very easy. But if they are not transplantable, their simple question is how long do you want to treat me, and how you want to manage me? How you answer this question in your clinic?
Yeah, definitely. Yeah, this is what. But there's now more and more patients who do very well under that combination. So what has been published so far tells you that you should at least give it for a year, and then you might consider to stopping. Yeah.
So my question is, so when you are giving, is there a definite treatment frame, or you have to continue the treatment indefinitely until or unless there is something happening at the undue toxicity or something else?
Oh yeah, usually we continue the treatment for 1 year. And if the patient is then still in complete remission, you can think of stopping it.
Okay.
Yeah. So, yeah.
Thank you, Samya. Another question from the audience. In a high-risk AML, dose ARA-C consolidation or switch over to alternative therapy like venetoclax-aza, especially because high-dose cytarabine is ineffective in high-risk AML?
Yeah, that's a good question. I mean, if transplant is no option, then I think a patient has no benefit from intensive induction, especially as you cannot really consolidate then very well the treatment effect. So I'd rather go for Ven-Aza, because there you have at least CR rates in the 50% range, and some of the patients might not relapse. But on the other hand, as I had shown you on these curves, many of these patients, I mean, the outcome is identical if you treat these patients with Ven-Aza than with azacitidine alone. This is also what we have not discussed. This is what we do. If you do not see any response after 2 cycles of Ven-Aza in a patient, what we then usually do is we stop the venetoclax, because you usually see the effect with venetoclax in the first 2 cycles. But then nevertheless, those patients can of course respond to azacitidine monotherapy. And there we know that you should at least do 4 to 6 cycles. So what of course the in-label would be that you continue the combination for 6 cycles, but that's of course expensive. So if we do not see any response to venetoclax, we usually stop it after 2 months and then continue with azacitidine alone, because there still you have the chance that 20% of your patients will respond.
Thank you. That was from Dr. Smita Kayal. Now, Deepak, your question.
Sir, I have a 37-year-old young fit male, AML with MDS-related trisomy 8 changes. He had a 7+3 induction, after which he had a persistent disease. We gave him a second induction. Post second induction, he still continues to have a residual disease. He has a 10/10 matched sibling. Would you go with the transplant at this point, or would you still consider chemo to get him to a remission?
Yeah, that's also a good question. And we also all face these problems. I mean, if you have the feeling that the patient is completely chemotherapy resistant, the question is always, how many more attempts do you do to really try to control the disease? And you then add toxicity and with regard to the transplant, and you might run into problems. So what we usually now do really is, in that patient, depending on what you had done for the first salvage, we try to do a let's say an innovative protocol where we add venetoclax to the chemotherapy, and there we have very good success rates that you can control the disease, and then you move forward to transplant, like FLAG-IDA plus venetoclax, something like that.
If I ask.
Yeah, Deepak, you have more questions? Yeah.
Sir, my second question was, in your slides, you in the classification, so there was a 17p and a TP53 mutated AML. So is there a difference in the way they respond to treatment or biology of the disease between these two?
Yeah, there's a more or less no. There's a huge overlap. Most of the P53 mutant ones, or most of the deleted ones, also have a P53 mutation. There is few that have only a monoallelic deletion without P53 mutation. They do a little better, but numbers were small with regard to the analyses that are out there yet. But this is, for example, something which we are now looking into at our Harmony Alliance. That's a huge pan-European effort to put data sets together. We now have in the database over 30,000 AML cases with cytogenetic information and molecular genetic information. And there we now can do these subgroup analyses and look especially at these questions. So long story short, more or less, they are equally poor. There might be a subgroup that does a little better, but nevertheless, we would not make a difference with regard to management.
Thank you. 30,000 cases, phenomenal. Okay.
Yeah, that's cool.
Fantastic. Satish Kumar has not asked any question. Go ahead, Satish.
Thank you, sir. Dr. Lars, you mentioned just recently asked the question about the induction failure. So can you elaborate, how do you deal with induction failure, 1 3+7 young patient? What do you prefer, giving 3+7 once more, or give HITAC as an induction salvage? How do you go about induction failure?
Yeah, so this also depends a little bit on, I mean, if let's say that the blast count did not change at all, then we usually do not do the same induction a second time. If you have at least a partial response, then we would go for a second induction, because then the rate of patients is not really small, where you then still can achieve a CR. But if there was completely no action of no activity of your regimen in the first run, then we already switch for a salvage regimen for the second one. And then usually we use, like in the past, we used FLAG-IDA without venetoclax, but now we add venetoclax to that.
So FLAG, venetoclax.
Yeah.
Thank you, Dr. Lars.
Thank you, Satish. Another question from audience is related to 10 days of decitabine with venetoclax in a patient that has failed aza-ven. Will you recommend?
So if aza-ven did not work, then decitabine-ven?
10 days with venetoclax.
Yeah, there is some data that the higher dose, to be honest, I do not have experience with that. The question is a little bit did he fail venetoclax or did he fail the hypomethylating agent? I mean, you can give it a try. It's definitely, I mean, given the fact that there is not so many better options there, I would give it a try. What we usually do if patients relapse after ASA, we definitely do molecular genetics again, because you might have selected, for example, for an IDH mutant clone, then we would move forward to an IDH inhibitor. Or you can also have relapses where patients suddenly turn FLT3 positive, even they were FLT3 negative in the beginning, and then we would use gilteritinib as relapse strategy. But if those two are not available, then we definitely would, yeah, you could give it a try. Definitely, there is data out there, and better than to do nothing.
Right. Another audience question is, do you ever use midostaurin, IDH inhibitors, and gemtuzumab as single agent in relapsed patients' palliative setting, or link them up with ven-aza, etc.?
Yeah, midostaurin as single agent, not very effective. Definitely would recommend gilteritinib, very potent drug. And if FLT3 mutant patients relapse, we use gilteritinib as that's our treatment of choice in relapse, much better than even intensive chemotherapy in these patients. And then, of course, also try to get them again in a CR and then move forward to transplant. Midostaurin in combination with ven plus aza, there is good data that addition of a FLT3 inhibitor can further improve synergy. But it's not standard of care. We usually do not do it. We go with either version. And what was the last one? Sorry.
IDH inhibitors as single agent.
As IDH inhibitors as single agents, they are effective. They are approved for that in the US, but I think the combination with ASA is much more potent. And I think gemtuzumab was not the question. Gemtuzumab as single. Yeah. So gemtuzumab is approved as single agent for relapse leukemias in the US. Unfortunately, not in Europe. But we nevertheless once in a while use it in patients that have no other options, and we also have made good. I mean, it's few cases, but once in a while patients really respond, and you can control the disease again. So yeah, yes, we use it once in a while, even though it's not approved.
Right. Dr. Verma.
So in a patient with AML, due to baseline like fungal infection or pneumonia, we started with azacitidine, and after 1 to 2 cycles, The patient's performance status is quite good, and the patient does not have any active infection. So now we are planning for induction. So do you recommend 7+3 or 5+2 in that situation? Do you see more toxicities of 7+3 in the background of use of azacitidine or destabine?
It depends a little bit on the age. How old was the patient?
The young patients are young patient.
Oh, young. Then we definitely would go for the full dose, and usually we do not see problems. Yeah.
Thank you, Dr. Verma. Dr. Vinayak Chikodi wants to know, is the FAB classification obsolete?
Yeah, more or less. If you train your students, not. I mean, it's the not otherwise classified cohort really, where you then still label the cases according to the morphology, and that's more or less the old FAB. It's not called that way anymore, but it will be fewer and fewer cases with all these new molecular markers that go into that. But on the other hand, I think it's still good to know the old FAB. Especially as if you have this myeloid differentiation in the cells, you frequently see these problems like CNS involvement, extramedullary disease, and we more carefully look for that in these patients. So it's also good to still look through the microscope and know that you are a hematologist.
Thank you. Dr. Upendra?
Dr. Lars, I have one patient, so a young fit patient, normal cytogenetics, intermediate risk, received 3+7, failed, then received 2 cycles of decitabine plus venetoclax, failed, then received 1 cycle of flag-ida, that also failed. So how we should proceed to this patient? Directly transplantation, high-dose therapy, or anything else?
Yeah, what normal cytogenetics? Now, what was the
normal cytogenetics? No molecular markers positive.
That's strange. Yeah, it doesn't look like it's a it's one of these tough cases, right, where you do not really have a good answer. Usually, we try to move forward to transplant, even if it's not controlled. I mean, you didn't give HMA a try yet, did you?
Decitabine plus venetoclax 2 cycles.
Oh yeah, it was already in there. So then rather, give transplant a try. Young patient, but knowing that the chance of success is low, right? But this is, for example, this is a patient where I would have thought that it's an inversion 3 or something really bad. Yeah.
So can I ask one other question?
Yeah, go ahead.
So I have another patient, say elderly patient, not fit for transplant. She is FLT3 positive, received triple drug with venetoclax, azacitidine, and midostaurin. 6 cycles, she's in MRD negative status. So how to proceed further?
Yeah, I would give at least 6 more and then think about stopping, or perhaps then stopping the aza-ven and continuing the midostaurin as a maintenance.
Thank you.
Thank you, Upendra. Another question from audience is regarding CPX351. Outside therapy-related AML and AML MRC, are there any other indications?
So, sorry,
regarding CPX351.
No, I got it. So far not. We are doing currently a randomized trial together with a Dutch study group where we are comparing CPX351 against 7+3 in all patients. And the idea would be whether this could really then be the new backbone. But so far, that's the label, and this is what we use it for. Yeah.
Another question.
But I'm afraid I will have to leave now in the next 2 or 3 minutes. So I think 1 or 2 more burning questions back. Otherwise, my mother will be mad at me if I do not show up for breakfast.
You have really been bothered by all this, bombarded with questions. So, Roshni, very quick question. Do you have a short one?
In therapy-related AML with no access to CPX351, should we go for aza-ven followed by transplant, or something like flag-ida followed by transplant, understanding that reinduction will have a lot of toxicity?
Yeah, but this is exactly what I would do in these cases. And definitely try something new that's better than classical 7+3, where you frequently do not get anything out of it. But the two valuable approaches. Yeah.
Yeah, thank you.
Thank you. What we will do, I will send you the email ID of Dr. Buliga, and he will answer your questions. I'm sure he will do that. So we will stop here. Thank you very much, Dr. Buliga. That was fantastic. And you had tremendous patience to answer all the questions. And we have official vote of thanks from Sumit. Please go ahead.
Yeah, thank you, Dr. Lars Bullinger, for sparing your valuable time on this Sunday and joining us for this webinar. It was a lucid presentation, and we have many key takeaway points from this presentation. It's really interesting to see the changing landscape of AML management. We also learned about the updates on classification and evolving role of different drugs with a focus on CPX 351. Thank you so much for keeping us abreast of all the newer updates on management of AML in 2022. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal for providing us this wonderful opportunity and making us a part of this elite academic discussion. I also thank the chief guest, Dr. Sriram Kane, all the discussants and participants who have joined us for this webinar. Thank you so much and have a lovely weekend.
Thank you very much again for the invitation.
Thank you on behalf of Mumbai Hematology Group, and we will love to call you to India, and I hope you'll oblige.
Yeah, definitely.
Bye-bye.
Bye-bye. Have a nice Sunday.
Thank you.
Bye.
Thank you.